Hello everyone. I would like to begin by thanking Team YOSI for initiating this fantastic effort. I'll be discussing microbial keratitis now. Microbial keratitis can occur due to several risk factors. Ocular trauma, especially with vegetative matter, is commonest cause. Contact lens wearer, particularly overnight use or maintaining a poor hygiene while wearing contact lens, can lead to microbial keratitis. Systemic conditions like uncontrolled diabetes or immunosuppression to make the eye more vulnerable. Using topical steroid can worsen the infections, while exposure to contaminated water such as swimming with the contact lenses adds to the risk. Microbial keratitis can be caused by a variety of pathogens. Bacterial infections commonly caused by the Pseudomonas aeruginosa, Staph aureus, and Streptomycin. These are often aggressive in presentation, while fungal keratitis typically from Fusarium or Aspergillus species is frequently seen after the trauma with the organic matter. Viral infections, particularly from HSV virus, can cause recurrent episodes. Acanthamoeba, a parasitic cause, is most common in contact lens users and is notoriously difficult to treat. Additionally, atypical infections like Nocardia species can present in chronic cases. Recognizing these pathogens early is key to effective management. Bacterial keratitis typically appears as a central or paracentral ulcers with a sharp margins, stromal edema, and possibly hypopyon, while fungal keratitis, especially from the Fusarium or Aspergillus, often has a dry, feathery infiltrate with raised edges and satellite lesions. If you see the nocardia keratitis presentation, it's a distinctive, presenting as a multiple small pinhead-sized infiltrates with a cracked glass or weight-like pattern. HSV keratitis classically shows branching dendritic ulcer with a terminal bulge, which can progress to large geographic ulcer if left untreated or in the presence of steroid use. Fungal and bacterial keratitis differ in presenting and progression. Bacterial keratitis is typically acute and aggressive with a dense and well-defined infiltrate, rapid stromal necrosis, and even significant inflammatory response, often leading to hypopyon. In contrast, fungal keratitis has a gradual onset and appears as a dry, feathery infiltrate with irregular margins and sometimes even with the presence of satellite lesions. Fungal infections are more common after trauma with the vegetative matter. Keratitis diagnosis begins with a slit lamp examination, and understanding the ulcer morphology is very important. To objectively track the response, we can sketch the ulcers on the case sheets, noting its size and features at each visit. This allows precise comparison over time. Microbiological testing is equally and critically important, like doing corneal scrapings for gram staining or KH mounting, and even sending sample for the culture sensitivity help us to tailor the therapy. Once a keratitis is diagnosed, treatment should be initiated promptly. Empirical broad-spectrum antibiotics such as fortified vancomycin, fortified ceftazidime, or fourth-generation fluoroquinolones are first line for the bacterial keratitis. For fungal keratitis, natamycin or voriconazole is preferred, while azithromycin is essential if HSV keratitis is suspected. Cycloplegics helps in relieving the pain and even it also prevents the formation of synechiae. And frequent lubrication supports the healing. And therapy should be guided by clinical response and microbiological results, which ensures the optimum outcomes. Monitoring and adjusting treatment in keratitis is crucial for optimizing the outcome. Patients should follow up within 24 to 48 hours to assess response to the therapy, and based on the culture results and antibiotics or antifungals should be modified. Counseling plays a very important key role. Explain the prognosis clearly and stress the importance of regular follow-up to the patient, to the attender. Patients must avoid home remedies as can worsen the infections. If symptoms deteriorate, an early consultation is essential. For contact lens users, proper hygiene education is necessary to prevent the recurrence. Proactive monitoring and patient awareness ensures better visual recovery. When ulcer fails to heal despite medical therapy, surgical options are necessary. A therapeutic keratoplasty is performed for deep ulcers or perforations to restore the corneal integrity. In cases like neurotrophic keratitis, where healing is impaired, amniotic membrane transplantation provides essential support for the regeneration. These are the references I used to gather information for this presentation. Thank you for your patient listening.